Hello everyone, here is Emad Magdy speaking to you, and the first lecture in the series of lectures of the medical emergencies in the emergency room. As I mentioned in the introductory presentation, the whole theme of the 3 weeks is to how to approach the urgent presentations in the ER. So you will find all the lectures in a collecting manner, not get deep into the academic knowledge of each topic, but concentrating on how to approach, how to diagnose the case in the ER, and how to manage or urgently manage the case in ER. We'll start today with the first presentation of the week is the circulatory failure in emergency. How can we manage circulatory failure in the emergency? Because it is the first lecture in the module, I will speak to you about the ER golden rules first, and then go to the topic itself, the hypotension, shock, syncope, acute heart failure, life-threatening arrhythmias in ER. The ER golden rules that any patient presenting with an acute or emergency condition need a quick thinking, a logic thinking from the clinician. ER doctor needs to be immediately aware of the principles of resuscitation, diagnostics, and giving the priority of the patient of the clinical intervention, priority of the even taking the knowledge from the patient, as I will mention in the next slide. What are the 3 principles we will concentrate on? Those 3 principles don't have fixed order. One of them may take the priority and the other may take the second priority according to the situation of the patient, according to the presentation of the patient. Not infrequently, the diagnosis in the ER will be unclear. Despite best efforts, and presenting syndromes or scenarios such as shock or breathlessness will need to be dealt with in a systemic and logical manner. The clinicians will need to overcome their own anxiety and perform quickly, efficiently, and professionally. So this is the second challenge in the ER. So number 1, I'm dealing with an urgent situation. This situation is difficult. This situation is stressy. This situation is sure the patient coming with his relatives or her relatives who are anxious, making stress on me, making stress on the health service. So it is not only the knowledge, not only the knowledge I know or I can help the patient with, but to manage this knowledge in a wise way. So this old story of the turtle and rabbit, the slow and steady win the race, no, here it's not valid. The fast, the organized and steady. So we need the turtle and need the rabbit at the same time, not one skill of them. Some other rules, it should be remembered that in most cases the history is crucially important to the formation of differential diagnosis, and this is again another challenge. Why? Because the theme in the ER, I don't have time to take history. So how can I pick the very important or the most important items in history that help me to reach the diagnosis in the right way and in a very fast way? If the patient cannot communicate verbally, as frequent in the emergency department, every attempt should be made to take a collateral history. A collateral history means a history not from the patient himself or herself, but from the relatives, from the past medical histories, documented past medical histories, like the follow-up cards within the hospitals or documented hospitals or with any doctor. A poorly taken and rushed history followed by numerous irrelevant investigations is a poor quality medicine. We should know this. We should know that any health service need a doctor who can manage the instruments, who can manage the costs, not only just asking for more and more investigations, more and more rushing in the investigations, which consume the health service. So what are the three principles you should not forget? Those are the principles I mentioned in the first slide. We have three targets in the ER. Number one, diagnosis versus resuscitation, and this is challenge number one. All the targets of the doctors is to diagnose the illness, so start the right treatment, aside the right treatment plan. But in the ER, we have another issue, the resuscitation. So who comes first, the resuscitation or diagnosis? The patient presentation will determine this. In some patients, we start to resuscitate even before knowing anything about the history, anything about the diagnosis of the patient, but the patient is in a life-threatening condition. The vital signs of the patient is in life-threatening situation, so I have to resuscitate whatever the diagnosis, whatever the history. Number two, the scenarios outside the emergency department. When we faced with a patient with shock, with confusion, with any urgent situation, again, the situation is stressy and make me anxious. But the scenarios before this situation or before this presentation is very important in tailoring the management plan of the patient. And the third rule is the logic rather than lists. We study a lot of causes of any illness or any disease, but to differentiate between the causes, to get the way and the differences between the causes, to judge a provisional diagnosis, it needs a logic test, a logical test, not a just dotted and numbered lists. I will apply all these three principles on the clinical presentations we will discuss in this lecture and in the lectures of the other weeks. So we will take the all the material as a clinical presentation. We don't study certain topic here. We study a presentation in the emergency department. The first presentation we will discuss is the hypotension, syncope, and shock. Why I put them in this manner? Because the presentation is quite confusing and may carry some sharing points between the presentation, sharing point between the how the patient is presented. It carries some difficulty to differentiate between those three presentations in the ER. So we will take them as a one package: hypotension, shock, and syncope. Number one, the terminology. Before applying the three principles, we have to get agreed with some terminology. Again and again, this terminology is very important when I introduce a case or introduce a case to a consultant or to anyone, to any other medical professional to take his opinion in the case or take his decision in the case. So we should all speak a unified language. The terminology in the hypotension, shock, and syncope, there are numerous definitions of shock. But the most accurate one is that the shock is a state of insufficient perfusion to major organs. Whatever the cause, whatever the mechanism, whatever the pathophysiology, there is no sufficient perfusion to major organ. Hypotension is abnormally low blood pressure for that given patient. Okay, يعني would like to stress on every single word in this sentence. Abnormally low blood pressure. Okay, so hypotension means low blood pressure. If it's accompanied by low signs or evidences of insufficient perfusion to tissue, it will be shock, not hypotension. If not, it is just hypotension. Why I told you this? Because many times a day you will have referrals that this patient is in shock, and you will start to ask about the signs and symptoms or evidences of insufficient tissue perfusion, like the confusion. If insufficient blood to the brain, it will lead to confusion. Insufficient blood to the kidney will lead to reduced urine output. Insufficient blood to the heart may cause a chest pain and low cardiac output symptoms. Insufficient perfusion to the skeletal muscles will cause muscle pains and something like that. All these are evidences of tissue hyperperfusion or major organ hyperperfusion. The first and very important priority to ask is about the urine output, because the kidney is a highly vascular organ, so it's very sensitive to the diminution of the perfusion, so it will manifest early with oliguria. But only low blood pressure is a hypotension. Do we have certain limit of blood pressure below which I can describe the patient with hypotension? No. The low blood pressure is compared to the known for that patient, which means that I have to interpret the documented blood pressure in context. For one patient, a normal blood pressure may be significantly lower when compared to previous reading. In another, a low blood pressure may be entirely normal for that specific patient. Okay, I think this idea is clear now. So this is the shock and this is the hypotension, and let's talk about the syncope. The syncope accurately is a state of temporal loss of consciousness. Okay, so the terminology of syncope not gathered 100% with the hypotension. Sure, it can be due to hypotension, but the syncope doesn't include in the definition hypotension. It's a temporal loss of consciousness, usually related to the insufficient blood flow to the brain. It's also called fainting or passing out. It most often occurs with hypotension and the heart doesn't pump enough oxygen to the brain. It can be benign or a symptom of an underlying medical condition. Okay, so we now get the differences between the three terminology. Let's start with the syncope. We will now apply the three principles. In syncope, if we think academically or in a basic manner, so if I have a patient with syncope, I will try to think about the etiology of syncope. So this etiology, this usual list, oh yes, I study that the causes of syncope may be situational, vasovagal, neurogenic, cardiogenic, orthostatic, psychogenic, drugs can cause a, okay, this is a very good in the exam, but in the ER I should be more concentrated on the three principles. Number one, the following questions should be asked. Number one, the principle number one is the diagnosis versus resuscitation. Here, this question should take the priority. I have a patient with temporal loss of consciousness, so I don't have to rush to diagnose the cause before knowing that this patient is in need of resuscitation or not. So, was the loss of consciousness is complete? Was loss of consciousness is rapid and of short duration? Was the recovery spontaneous, complete, or without sequelae? Was postural tone lost? As you see, those four questions are very important. Why? Because all the common causes of the syncope will be related to the cardiovascular system or the neuro or the CNS. So I should concentrate my questions on the most important and most logic and most common causes first. So if I return back to the on the left side, this is the usual list or the academic list. On the right side, there is a logic list, and this is the type of lists that I can use in the ER. As we see here, in history, I should ask about nausea and vomiting before collapse, syncope with exertion, seizure features like tongue pitting, incontinence, post-collapse disorientation, why and why again, nausea and vomiting before collapse. What? How can indicate it? May be due to vasovagal attack. Okay. It may be due to circulatory collapse. Maybe. Syncope with exertion. Yes. Again, it can direct me to think about the cardiovascular causes like the arrhythmia, like the hookah, like the the hypertrophic obstructive cardiomyopathy. So it's a very important question I should ask first. History of cardiac disease, arrhythmia, heart failure, ischemic heart disease, aortic stenosis, previous syncope, seizures, and then at the last the psychiatric and the current medication. So don't let your patient she's psychic, she's just stressed, someone got her angry. You should not think like that. You should at first exclude the common causes and the specific cause. So in the ER you have to make the logic list. Logic list means that I have common causes, I should exclude first, then risky causes. It may not be not common, but if I miss this cause, I will harm my patient very much. The physical examination should rely on the orthostatic hypotension, or regular or slowing rising pulse. So the vital signs, the comparing between the recumbent and standing blood pressure is very important to discover all the autonomic neuropathies, all the autonomic dysfunction in the control of the blood vessels. Should check for the pulse, and you should know that the diagnosis of syncope is mostly based on the history and examination, because you should know that the highest diagnostic yield from postural blood pressure measurement, this is a very important diagnostic yield, and the lowest diagnostic yields from the CT, carotid ultrasound, EEG, and cardiac enzymes. So those are advanced and costly investigations. We will offer them to all the patients with lost consciousness. But if you exhaust yourself in the history and the examination with a very simple exam to do the postural hypotension, it may benefit you more than a head CT or carotid ultrasound or EEG. Those are the most important 4 questions in the history. And this is the resuscitation. In patient brought to the emergency department with a presumptive diagnosis of syncope, appropriate initial interventions include the IV access, oxygen administration, cardiac monitoring is more important than discovering the cause. And then again another example of the logic lists in management of shock. So after taking the important history and the examination data, so the cause of syncope may be very simple or may be provisionally very simple, because we don't have to get confirmed or anything, but probably there is no cardiac signs, there is no history of cardiac disease, there is no history of neurological disease, there is no evidence of seizures or epileptic attack or something like that. So we can categorize the patient to low risk, neither high nor low risk, or high risk patient. For the low risk, we likely have reflex or orthostatic. This can be discharged directly from the emergency. Neither high or low or any high risk features, I should do all my best in the investigation, even the sophisticated investigations, and admit the patient for diagnosis and treatment. If the patient neither high or low risk, should not be discharged. I should give him a period of 24-hour admission, then evaluate the situation again. If it is required, I can admit him for a longer time and the more sophisticated investigations, and I can discharge him or her. Okay? Do you apply now the three principles? resuscitation first, logic lists. Logic lists mean that the lists that help me to diagnose the patient very rapidly and help me in managing the patient. Okay, help me in taking a decision of discharge this patient, admit this patient for only 24 hours. Because one of the challenges in the medical practice that we have a very limited beds for many population. So we have a challenge in this to reserve the seats or reserve the beds to the patient in more severe or more urgent situation. It's not easy to admit a patient to the hospital, and sure, it's not easy to discharge him while he or she needs the care. This is for the syncope. Shock. We will apply again the 3 principles on the shock. In the shock, sure, the resuscitation comes first, because we have, as we will mention in the next slides, we have multiple causes for shock, multiple definitions, multiple lasts, multiple management techniques, but we should know that shock means insufficient oxygenation or perfusion of the major organs. So we should correct this because it's a life-threatening problem. So it's a good practice to begin intravenous fluids while other clinical features and vital observations are elicited. The fluids may be subsequently stopped if any sign of overload like the pulmonary edema become evident. If more than one clinician is available, it will be good and okay, because one may focus on history taking while another take responsibility of the examination and the installation of the resuscitation treatment. Examination findings, irrespective of the cause, may include a rapid pulse heart rate and third heart sound. Okay, so again, if I'd like to diagnose shock, I should have low mean arterial blood pressure, sign of major organ insufficient perfusion, and sure hyperdynamic circulation. It should be noted that in the face of severe hypovolemia, there may be a prolonged period of compensation in which the healthy heart maintains the cardiac output and normal blood pressure by increasing the heart rate. Therefore, the patient with unexplained tachycardia should be examined and investigated thoroughly, and bending shock should not be missed. What the meaning of this sentence? That we can meet the patient in a state pre-shock or a state of compensation. So when the perfusion to the major organs decrease, by compensation the heart decrease the heart rate to decrease the stroke volume, increase the heart rate to increase the stroke volume, and subsequently increase the cardiac output, and subsequently increase the tissue perfusion. So the unexplained tachycardia should be assessed as a possible bending shock in the way. The assessment of the volume status of the patient, the items to give fluids or not, the idea of fluids, all these concepts will be discussed in a separate lecture in the end of the week, also by me, by the IV fluids. How can I assess the patient in need or not in need for fluids, the types of fluids, the fluids usage in resuscitation. All this will be in separate lecture. In the end of the week you will find another video uploaded to the module. So this is number 1, principle number 1, resuscitation. Principle number 2, logic rather than less. If I ask you what are the causes of shock, you will tell me cardiogenic, maybe the cardiac, maybe septic, maybe hypovolemic, and under this many causes. Again, this is the academic less, but here I'd like to assess rapidly. So to define the shock or the most common causes, I will pass to a very simple step in the examination. assess the pulse pressure, assess if the hands are cold or hot, the patient is dry or wet. So the assessment volume status, the assessment of the pulse pressure, the assessment of the warmth and coldness of the hand. So any narrow pulse pressure shock, I have two only differential diagnoses: narrow pulse pressure shock or widened pulse pressure shock. Under the narrow pulse pressure, maybe the hypovolemic, maybe cardiogenic. Under the widened, maybe septic, anaphylactic, and neurogenic shock. Those are very important items we should know in the assessment of the logic lists of the shock. As a general rule, patient with widened pulse pressure will present with warmer peripheries, and the palpable peripheral pulses may be more pounding in nature. Okay? Okay, the next one. Patient with narrow pulse pressure often possess a cooler peripheries with 3D peripheral pulses. Sure, it's logic. Although normal pulse pressure is often quoted as 40 mm mercury, it should be noted that during the hypotension, this figure should be interpreted with caution. For example, if the blood pressure systolic is 75 and diastolic is 40, could be interpreted as having widened pulse pressure of 3.35, as this is the context of low systolic blood pressure. So it's not, again, it's not an absolute number, it's a relative numbers. This is idea number 2. So idea number 1, the wide pulse pressure, pounding pulse, and warmer peripheries. The narrow pulse pressure, cooler peripheries, and 3D pulse. I should assess the pulse pressure in a relative manner, not an absolute manner. The third idea is that there may be mixed forms of shock. For example, it's not uncommon for septic shock to rapidly lead to cardiogenic shock. Why? Because the septicemia can cause cardiotoxemia or cardiac muscle toxicity. So maybe the patient presented with both of them. Septic shock is also associated with hypovolemic shock because it's a capillary leak, a state of capillary leak, and the plasma escaped to the third space and to the interstitium. So the blood inside the vessels will decrease more and more, and this is the effective intravascular volume. You will know about this term in the IV fluid lecture. So may be accompanied by hypovolemic shock. It's also not uncommon for cardiogenic shock to improve with treatment to be superseded by infection and septic shock. So the mix between the types of shock can be this is again the definition of wide pulse pressure and low pulse pressure. The commonest cause of wide pulse pressure is sepsis, and less common are the anaphylaxis and vasomotor tone neurogenic shock. The narrow pulse pressure, cardiogenic and hypovolemic. Again, those are the differences in a more organized manner. We have another classification or some terminology we should know, because you may face it in the exams or something like that. The other classifications, we have hypovolemic, distributive shock, cardiogenic shock, and obstructive shock. And those are the causes. You can read it. It's very, very simple. Okay. The hypovolemic shock occurs due to inappropriately low intravascular volume, and this is what I meant by the effective circulatory volume, leading to decrease the preload, decreased stroke volume, and decreased cardiac output. Maybe due to severe hemorrhage, further decreasing cardiac output with primary compensatory response of autonomic nervous system, increased systemic vascular resistance. The distributive shock, there is a profound systemic vasodilatation, was what I meant by the capillary leak syndrome or systemic inflammatory response, is commonly associated with relative intravascular volume depletion. Relative means what? There is no decrease in the total body water, but there is no enough water in the intravascular space. So all the water escaped to the interstitium. So I have the water in unnecessary space in the interstitium, so making the patient look like edematous and swollen, but in the effective circulatory volume, the intravascular space is deficient. and this is a problem. So the major organs will not be sufficiently perfused. Up to 40% of patients with distributive shock due to sepsis may develop a transient cardiomyopathy. Septic shock is the most common cause of distributive shock. Obstructive shock, another term common in exams. Obstructive shock results from either a critical decrease in the preload or an increase in the left ventricular outflow obstruction. So extracardiac process that increase the intrathoracic pressure can result in obstructive shock by decreasing the cardiac compliance and interrupting venous return by compressing the inferior or superior vena cava. Some very important terminologies in the case of sepsis. You will face this situation again and again, and you will have multiple referrals of patients with sepsis, septic shock, severe sepsis, and we get confused of just highlighting the patient with any of these diagnoses. You should know that we have certain criteria for diagnosis of each terminology of this. So the systemic inflammatory response is a diffuse inflammation in the body, blood vessels, diffuse vasodilatation, not sure be induced by infection, maybe by allergy, maybe it's an inflammation, not an infection. But we have these clinical criteria to judge this situation. If those clinical criteria or two of them is accompanied by confirmed or suspected infection, it is sepsis. So I can label the patient as have sepsis. So what is the severe sepsis? The severe sepsis means sepsis plus sign of end organ damage or hypotension or increased lactate level in the blood. What is the septic shock? Septic shock is a severe sepsis with persistent, the three signs of end organ damage, hypotension or increased lactate level in the blood. What's meant by the signs of end organ damage? End organ damage means the major organs affected by the diminished perfusion. The major organs is the kidney, the heart, the brain, and liver. Okay. What is a neurogenic shock? Neurogenic shock which result from widespread and massive vasodilatation. This is the pathophysiology. You can read it. It's very easy. I know you know about this. The most common causes are the spinal cord injuries, spinal anesthesia, vasomotor center depression, and this should be evaluated first, the vasomotor center depression, because it is more more common than the spinal cord injury and the spinal anesthesia. And those are the signs and symptoms of anaphylaxis. Come to the last one. I will join it with the next topic, the acute heart failure. The cardiogenic shock. Cardiogenic shock due to failure of the left ventricle to generate adequate arterial flow to deliver oxygenated blood to the peripheral tissues. Cardiogenic shock may be due to disruption in stroke volume or heart rate. Failure of the left ventricle to generate adequate oxygen delivery may be due to process such as right ventricular failure or valvular heart disease. So the cardiogenic shock, from its name, means that there is decreased cardiac output. The main pillars of the mainstays of the cardiac output is the stroke volume and heart rate. So if there is a muscle problem or a heart rate problem, it may cause a drop in cardiac output and cause cardiogenic shock. And this drop can be acute or acute on top of chronic heart failure. So if it is on top of chronic heart failure, I should have the evidence of chronic or congestive heart failure of the patient, and something exacerbate this congestive heart failure or this compensated congestive heart failure to decompensated one, or from the start it's a normal heart but develop an acute heart failure. Again, those are the principles. Those are the academic lists. We have the causes of decreased stroke volume, causes of the decreased heart rate and the life-threatening arrhythmias. I will discuss in the end of the lecture, but I'd like to highlight some issue: the acute heart failure. The acute heart failure represents the most common cause of hospital admission in the elderly and may contribute to a huge healthcare cost of heart failure. Those are the definitions and the etiology and the normal lists. But again, I in each presentation I put here all the academic lists, but I will skip to the logic list in the ER. But you can read it and you can revise your knowledge. I know that you take all these data before, but here I put it to you for just revise the common causes and the etiology of this heart failure. Acute heart failure is defined as a rapid onset of symptoms and signs secondary to abnormal cardiac function. Cardiac dysfunction can be all or related to systolic or diastolic dysfunction, or again to abnormalities in the cardiac rhythm, and those are the causes. Many causes. I know well that you read it before, but this is what the logic list I prefer to use in the ER. Why? Because I have a challenge in the ER. Not any cardiac patient will come to me in the ER shocked due to cardiogenic cause. Again, I will repeat it. Not any known cardiac patient come to the ER will and the presentation of him will be related to the cardiac condition. I should be neutral when assessing the patient. I know, yes, it's very important to know in the history that this patient is a congestive heart failure patient or a previously cardiac patient, but don't put all your suggestions in one way that this presentation is related to the cardiac problem. But relate your logics or your lists to the management. And this is why I prefer this classification in the ER. I should know if my patient in a very simple, so if you notice in the previous slides, multiple causes, we have tens of causes, but here I don't have time to do this. I'd like to manage the patient. So what will help me to manage the patient is to know just those few ideas. Is this patient is warm and dry, or warm and wet, cold and dry, cold and wet? Okay. Warm mean, as I mentioned, the extremities. Is it a wide pulse pressure shock or narrow pulse pressure shock? Why I prefer this? Because all how can I know the cold and dry from this? This is a perfusion. So the prolonged capillary filling time, cold extremities, syncope, skin paleness, oliguria, obantipulation. This is the signs of the low perfusion to the brain, and to judge is it wet or dry, I will search for the congestion symptoms and signs, and those are the exertion dyspnea, the cough or nocturnal dyspnea, orthopnea, jugular stasis, painful hepatomegaly, ascites, lower limb edema, S3 galoprism, and then put this diagram. So if I apply this very important diagram, patient with acute heart failure, bedside assessment, presence of congestion or not. If the patient is congested, okay, congested, wet or dry patient, so wet or dry. Then I will do peripheral perfusion test. If yes, so wet and warm, so this patient don't need IV fluids. It will get harm from the IV fluids. I should give him diuretics, vasodilators. If the patient not responding, I can make ultrafiltration to him. So it's not appropriate to give him IV fluids. But if the patient is dry and warm or dry and cold, if dry and cold, so the first management will be the fluid challenge. I will give him fluid challenge. If dry and warm, so the patient, I can adjust for him an oral therapy. Wet and cold patient, systolic blood pressure below 90, yes or no? Here, if he is wet and cold, mean that I have to give the perfusion, inotropic agents. Again, I don't need IV fluids. So as you see here, the management is based on a very simple criteria I can evaluate in the ER, and the management may differ completely from taking IV fluids to no, stop IV fluids, taking diuretics. So in the opposite direction, by a very simple two clinical tests, without any sophisticated investigations, I can manage my patient. Arrhythmias in ER, I don't take much time because we will have a seminar this week on the life-threatening arrhythmias in ER, but we should know something, that we study multiple types of arrhythmia. I should know which is more common. Not all the arrhythmias are presented in the same incidence or frequency, so I should know the common arrhythmias in ER. And as you see, the ventricular tachycardias, atrial fibrillation, AV block may may take the main quarters of the causes of arrhythmias in ER. Again and again, tachycardia, we should have a logic list like this: narrow or wide complex tachycardia, if narrow or if wide, regular, irregular. Again, this will help us to know the diagnosis and manage the patient. Again, I will not get deep into these approaches, but I'd like you to just have a concentration on one thing. Only 1, 2, 3 data, I will reach a very narrow differential diagnosis, and this is the type of list I should use in the ER. I should get trained to use it. So take the task this week. We have common presentations. We will take in all the week with all the cardiac and chest presentations. So chest pain, hypotension, shock, syncope, respiratory failure. We will take multiple lectures and seminars that will help us, but please think in this manner, test your approach, put yourself in situation and make your own logic lists. You will find some useful links in the uploaded on the Moodle from now, and you can enrich your knowledge in this topic. At the end, I really wish you fruitful 3 weeks in the medical emergencies. Take the task as a joyful and fruitful one. I'm sure you will get benefit from it. Thank you and goodbye.